Hey
Okay, perfect.
everyone. Thanks everyone for taking a few minutes here on a Thursday night. And thanks to Kinvent for sort of starting off this webinar sort of series on looking at objective approaches to various topics in rehab and performance. What I wanted to touch on today, is looking at patellofemoral pain, which has historically been a fairly chronic issue that is slow going, poorly understood at times, both in its inception and also in its treatment, and then looking at the acute versus chronic issues of it. But let me just start by introduce myself. So my name is Alex Shafir. I'm a physical therapist. I work at the Hospital for Special Surgery in New York City. I've been working in the sort of field, specifically in lower extremity and hip and knee preservation, return to sport sort of initiatives for about 15 years. And I think over the last really 5 or so, when insurance coverage has gotten tighter, and then more specifically in the last few years, in the last year and a half with the pandemic and having to shift to some telehealth and looking at really what are we doing when we're talking about objective measures? How do we make these things more both objective, user-friendly for both the patient and the clinician, because we only were able to spend just a certain amount of time with patients. I needed to get as much information as possible. Well, I'm fortunate to have found Kinvent about a year ago to start working with some of their equipment. So looking at patellofemoral pain in general, what we'll do is we'll sort of go through, we'll identify some basic anatomy, some classification, differential diagnosis, some pain generators, talk about the evaluation, and then look at the understanding of objective data and how it can be integrated to our treatment progression and evaluation. But really, this isn't about teaching anyone how to treat patellofemoral pain specifically. I just want to get on the same page in the beginning. But what I more want to do is take a look at how the integration of objective measurement can be looked at from a physical therapy standpoint in line with the evaluation and the treatment process, as opposed to trying to do a completely separate visit for measurements, which is sort of sometimes done. One sec. There we go. So generally, it's an insidious onset. Development can be slow or obviously acute with any kind of acute trauma. The diagnosis is made out of cluster testing, ruling out certain other issues. Pain with palpation of the distal pole, the patella, certainly at the patella tendon itself, the medial lateral facet of the patella, the femoral condyle. Patella compression testing can be done. But one of the things that I think we all see very often is that the compressive vector, the compressive forces of the patellofemoral joint with squatting, stair climbing, running, getting up from sitting are all clinically been found and from a research perspective have been found to be an issue with this population. So some of the pathoanatomy of the patellofemoral joint, it's made up of the articulation of patella and the groove of the trochlea of the femur. The patella is a sesamoid bone embedded in the extensor mechanism of the quad, increase the movement arm of the quad, protects the distal bony surface of the femur, and has multiple facets. The lateral articular facet here in green articulates the lateral femoral condyle, and this contact throughout flexion. The medial facet is generally a little bit shallower and not as wide, and has a lateral articular, medial articular facet, but really is more in contact during extreme flexion of the knee. Multiple pain generators, really what I'm getting at is multiple pain generators throughout the patella on the retropatellar surface that can be an issue, unloading them through different methods of rehab, but also different methods of activity modification are really something that obviously we all look at to assess whether or not someone is progressing or not progressing. Knowing when someone, and we'll talk about this in a second, in the acute stage of rehab versus in the more of the subacute stage of rehab, where we're not necessarily, we're starting to reintroduce certain things as opposed to really doing activity modification something that we want to explore and understand the anatomy and the kinematics of the joint to realize when we should be backing off and when we can sort of start pushing down on the gas. So the prevalence ranges obviously from, quite a bit, 3 to 85% in the anterior knee, depending on your source, and likely to the presence of pain from various structures, all being the potential source of pain, whether it's the fat pad, the patella itself, the patella tendon, any kind of OA, all is sort of classified as patellofemoral pain, which again is, I'll sort of say again how I started. The high prevalence and the high rate of reoccurrence, I think, all lead to the fact that these are very tough to treat when we aren't necessarily looking at whether or not someone's getting better or whether someone's not getting better. And I think sometimes these patients are very often treated, or even if they're in the performance setting, they're very often just seen, oh, it's patellotendinitis, let's put a band around it, let's tape it, let's take them days off, NSAIDs, price, whatever what might have. But if we're not getting better objectively, how can we really say that we are making a difference with whatever intervention that is, even if the intervention is just rest and time? So I think we need to make sure that we are sort of doing these patients a service by really grading ourselves and grading the rehab, no matter how slow or fast it might be. So risk factors, there's a host of internal risk factors of like femoral and tibial torsion, external risk factors that are listed here for the patellofemoral pain, but activity modification, identification of moving patterns all play a role. It comes up repeatedly in the literature that strength and the lack of quad strength specifically is really one of the things that is a significant risk factor, whether you have a isolated or primary patellofemoral patient, or you have a postoperative patient that develops patellofemoral pain. Quad strength continuously comes up as an issue. And we can really deliberate chicken or the egg, right? Is the weakness there because of an inhibition of the quad, or is the quad weak and causing the overload of the patellofemoral joint? That this isn't really the setting that we want to, I'd like to sort of talk about it. We certainly can, but the point today is really, can we measure it? Can we measure the quad? Can we measure strength without utilizing a biodex, without really having to get into a large scale sort of research facility? And then the other thing I think we have to think about is, if we're trying to strengthen a quad and we have to strengthen it through as much range of motion as possible, but we are just saying that increased range of motion, increased flexion is going to articulate with potentially painful structures, how do we actually methodically load the quad, knowing that we're not necessarily doing damage, and knowing that what the prescribed amount of load is, and what is that dosage? What is 20%? What is 50%? What is 80%? If we're utilizing BFR, how hard is hard? How hard are we pushing? What are we doing with these patients, whether we're doing, and again, we will touch on open versus closed chain stuff, but regardless of the exercise you choose, how are you grading the intensity of the exercise with some of these patients that are potentially a little bit more acute and aren't able to tolerate isometric knee extension of a certain weight in a knee extension machine? Or if you're more of a closed chain person, aren't able to do a step down, right? And they aren't able to do a standing terminal knee extension. How are you grading their ability to tolerate load? And how are you periodizing that load over time? So the thing we have to remember is, if we're going to be sort of honest with ourselves, if we bring someone into our clinic or bring someone into our facility and we want to tell them that the way we treat this insidious repetitive stress injury is that we're going to progressively load you, and we have to start at square one, whatever that one is, how do we actually know that we're building, as opposed to just, instead of just saying, well, we're just going to keep doing it until you feel better? And I think that's not enough for the patient, the clinician, or the insurance company at this point. And so, as we spoke about in 2019, clinical guideline classification, 4 subcategories based on the International Classification, Functioning, Disability, and Health. So overuse, overload, muscle performance deficits, mobility coordination deficits, and movement coordination deficits and mobility deficits. So once again, Yep. Noting some literature on strength, abduction, and quad knee extension peak strength, as well as poor neuromuscular control of the quad, were shown to be components related to patellofemoral pain, regardless of which came first, whether it's weakness or quad. At the end of the day, the weakness is there. We also started to take a look recently, in recent years, at the presence of some of the pain, patellofemoral pain causes sensitization, and further triggering some of the low threshold patellofemoral pain, without delving too far into really pain science, which is obviously a webinar or a discussion on itself. I think it's critical to understand that when we talk about loading the patellofemoral joint, what we may consider 20% MVC to the patient may be triggering a very significant amount of pain. And we need to be able to dial it back without scrapping the exercise entirely. And I think often, I know that I've done it in the past, where if a patient can't tolerate, TKE, I will immediately go to, or they can't tolerate a squat and they can't tolerate even a limited range squat, I'll just go right to quad sets. Well, how hard are they pushing? How much are they compressing that quad? How much are they activating that quad on that terminal knee extension, or on that squat, or on that quad set? Are we able to really differentiate the two? Because if we can get more bang for our buck in the quad set, maybe we shouldn't progress all the way up to a standing exercise. Or if we can get a little bit more grading of that squat, can we really reduce the amount they're loading that leg without necessarily reducing the range of motion, or potentially not reducing or not taking the exercise out altogether? So some things to really to think about, I think, because pain science and low pain thresholds, because of sensitization, is something that I think needs to be considered, needs to be in the conversation, or at least in the back of your head. So in the exam, again, this isn't necessarily the place to go through the whole thing, but we want to do, the objective today is really to go through and how we can help both us and the patient, as well as the insurance company at times, to better understand the progress this population is making. So specifically, one of the things we want to look at functionally is single leg balance, double leg squats, step down, and step up, right? All these other things we all look at to some degree. I think it's important to have a standardized way that you do approach each patient, so you can do a lower extremity screen and really go through it, rather than sort of reinventing the wheel every time. So during that time, while you're doing it, what I'll show you here is basically just utilizing, these are the portable force plates. These are they're Bluetooth, and basically in line with your evaluation, you prop somebody up on them, and what you'll see is just have the iPad running for whatever length of time you decide, whether it's 10 seconds, 20 seconds, 30 seconds, whatever you want. We can quickly take a look at some of the objective data, as well as the data that we're gathering as clinicians. And what I really want to stress is that we're not by any means saying that the report that's going to be spit out at the end of any one of these tests is something that's going to drive our care. What we want to see, and obviously her left side is a little bit more wobbly, a little more unstable. She's got a little bit of compensated Trendelenburg. She's got a little internal rotation on the left side. And then it falls into a little Trendelenburg altogether. And this is something that we want to observe and we want to note, but we also want to have some objective measures to quickly be able to note or attach to a chart or send to the patient or the doc or the parent if it's a young athlete case that you may say, look, they're just not ready. Same thing with a squat. We make a lot out of limb symmetry index. We make a lot out of hip strategy, valgus, adduction, things like that. But how well are we able to really see if there is a weight shift right to left? How well are we able to see it later on when we are looking at somebody squatting with any kind of weight? And I think that that's important to really note when the load begins to increase. Can we spot the deviation, and could we use objective metrics in order to do that maybe slightly better? There we go. So this is what, from the stance evaluation, this is the readout that you would see. And what you're looking at here is the stance symmetry on the right side versus the left side. And you don't necessarily need this paper in order to, or this readout, to tell you as a trained clinician that the left was more unsteady. But having that in whatever metric you want to use, whether it's this, whether it's the amount of weight shift or weight distribution, heel to toe, but your ability to do it, and you can have the center of pressure analysis as well. We've used this a lot, not with patellofemoral pain, but with concussion patients, with bilateral stance or single leg stance. And it's, you can very easily see it, especially with patients that are standing on 2 feet, whether it's patients with concussions or patients with balance deficits for whatever other reason. You can see the center of pressure begin to get smaller and tighter as they get a little bit better. And I think that's very helpful for them. It's very helpful to have a metric to go off of. Let's see. So, and then we get to the strength part of the examination. So we'll look at quad. We want to look at long lever straight leg raise, active range of motion against gravity, proximal hip stability, and core strengthening as well. So again, there's a ton of other things that other clinicians will involve into it. As I said, I want to touch on some things that we can sort of have metrics for. So this is one that, everybody is going to, in some way, measure hip abduction, right? Because hip abduction and patellofemoral pain, lower extremity issues go together. And your guess is as good as mine on whether maybe muscle testing is really going to, at some point, convince the insurance company that somebody's 3+ and then 4- is going to get them more visits. But as I said, having a pull dynamometer on somebody's leg that's attached to the bottom of the table, you can put it on a plate, and you can very easily get a strength measurement in pounds compared to the other side. You can do it in 3 trials, you can do it in 2 trials, you can do it in 1 trial for whatever many seconds you want. That's the one nice thing I found about the products, is because they're all app enabled, the app allows for a tremendous amount of flexibility for the prescription you want to use it for, whether it's the time, the repetitions, or the exercise itself. You can put in whatever exercise you want to use in whatever position you want, just using the hardware itself. And again, what's important to see here is that you're not necessarily reinventing the wheel on how to test hip abduction. We're just adding an objective measurement to it, while you as the clinician, whether you want to do it supine or side lying, you as the clinician are still observing their ability to do the appropriate motion, whether they're falling into hip flexion, whether they're able to sort of rotate slightly to get the glute med, however you want to do it. The other one here, the quad set, this has been a nice surprise for me, because I, probably like many people here, have always measured quad set as absent, poor, fair, good, right? And I think that's probably not doing the quad enough service, because we look for the quad and quad activation beyond fair and beyond good to be something. Because if somebody can't stand up and do a mini squat, or somebody can't stand up and do a terminal knee extension in standing, then we get them back on the table. But if they have a good quad set, well, what are we really doing? How hard are we really pushing into it? So having this little bubble device where you can, so there's perfect because the contrast isn't great, but there's a little like blow up. This could be anything. It could be a little ball. It could be whatever, like a little mini soccer ball. It could be anything that has air in it and has a hole for a needle that you would fill a basketball up with. And there's a little device that measures that pressure. And what you're doing is I'm putting someone into a quad set position, and you can strap their ankle down. You can do however you want to do a quad set. And certainly you can have a conversation on compensatory patterns from the glute and hamstring. But depending on how much they're able to push, if you can have the ability to measure quad strength, or measure quad set rather, in this way, you can now get an idea of, okay, in this position, obviously it's a soft table, in this position right now, today, here's your number, it's 80 pounds. There's no, to my knowledge, no standardization for quad set strength. But what you can do, and we'll see that in a couple of slides, you can leverage now what that person is able to do today to make them actually work out to that quote unquote MVC for the day. And that ability, I think, is what is even more important, because what you're then able to do is dial in exactly to whatever degree you want that patient to work at that day, whether you're doing BFR and you only want it to be 40 or 50%, or whether that patient is doing quad sets and you really need to get activation, or you're doing Russian stim with it. Whatever the case may be to you, the important thing is that you're doing an exercise that is actually prescribed and actually dialed in to the patient themselves, to what they need to be doing and when you're prescribing. So the data readout on that, just like as I said before. So what you'll get, this is the lower extremity strength. Oh, this is the quad set, right? So what you'll see here is, definitely a deficit on the left side. You'll see the max rep deficit, 16% there. The actual numbers, the mean of the reps. This is actually, so that's the mean of the reps there. And then you can actually, if you scroll down, what you'll see here is each rep will have a rate of force development. It will have time to max. Some of this may not be necessary for something like a quad set, but I think it is interesting because for certain other things, I've found, like if you're measuring Achilles strength using that little pull dynamometer, you want to see a high rate of force development, or you want to see limb symmetry between the two, because you need that Achilles firing, calf gastrocsoleus firing in a very fast way in order to generate force. So I think it's a nice metric to have. It's a nice metric to note. And it gives something to be able to submit. It gives something to be able to hang your hat on with progression or lack thereof. Let's get an overview of the stages of rehab, right? So that was part of our eval. We've got a sense of what we're doing. So phase one, again, this is a short review, but activity modification, addressing impairments, building foundational strength, restoration of function, and then return to play, return to sport, dynamic activities. Obviously, we're looking at precautions, assessment, treatment recommendations, and so on for each phase. So as you get into phase one, we're looking to get activation and strength of the quad, proximal musculature, as well as mobility and start cardiovascular progression. BFR is something that I've used, and many other people obviously have studied, sure to be effective, reducing the load in this population, especially while still getting quad activation and improving strength with low force, low compressive force, specifically over the patellofemoral joint. And so what you'll see here, this is before the BFR, but this is what I was talking about before, where now I can do this with BFR, I can do this without BFR, or I can do it with Russian, whatever. What you've got is now you have your max for that patient for that day doing their quad set. I'm going to take that number, I'm going to do whatever percentage I want of it, and I'm going to be able to play a biofeedback game with that patient, whether it is a 30-second game, a 60-second game, or I can go through an entire BFR cycle of 7 to 8 minutes and just say, okay, I want you to go 10 seconds on, or I'm sorry, an entire Russian stim cycle. I'm going to go 10 seconds on, 20 seconds off, 50 seconds off, 10 seconds off, whatever your duty cycle is going to be, but you can have them actually play the game to the cycle that is prescribed by you, the clinician, based on your clinical knowledge. Same thing with BFR. You can do 30 seconds on, 30 seconds off. And what you'll see is that they're going to be playing this game. You can choose the level, you can choose the time, as I said. And what you'll see is that they will be playing that game, and the harder they push, again, dialed into whatever you want them to do, the lower the, I don't know why it's a scuba diving kangaroo, but whatever it is, it's engaging to that patient. This is for the young athlete population, this is about as cool as it gets to be able to play, a low level video game. To the non-young athlete population, this is actually much more engaging because people are pretty into it. So I think that this is one of the things that really sets it apart from other measurement devices. I don't think Kinvent tried to reinvent the wheel here. I think they just tried to create a more flexible line of objective measurement by making it app enabled and making that app be able to be moldable by the company with input from clinicians, which I think is very, very cool. So as we go on, so obviously that was phase one. At some point, There we go. So in phase 2, we'll look at neuromuscular control. We'll look at single leg balance. We'll weight shifting, wobble board, contralateral hip extension, abduction, retro walking on the treadmill. Again, these are just sort of some of the review things that people will use, and we'll continue strengthening core, glute, open chain, closed chain, sort of quad strengthening as well. As I said, I don't want to get into a fight over open chain knee extension or isometric open chain knee extension. What I want to do here is, again, I think from my experience with physicians, open chain knee extension gets a bad rap. And I'm getting into it, even though I said I wasn't gonna, but it gets a bad rap because of the compressive force. But if you are able to know what the other side, that side potentially is able to do, what that MVC is, and dial in a small percentage of it, utilize like the Saga Smart Cuffs here, a BFR to do 30% of that, but get the training effect on the quad that is exponentially higher than what the load of the patellofemoral joint is, it's a win to me, and it's a win to most physicians. But again, understanding that you can't put 10 pounds of pressure on a knee extension machine and that's it. The weight of the sled itself, lifting it up and down, is going to be more. And I've seen these hooked up to Kaiser machines, sitting down, kicking out. But again, are you able to truly get a MVC on that Kaiser machine before? It's not measuring it, you're just setting it, and then now you're really loading the joint to find that MVC. And then you're trying to dial it in, where this is able to give you both a dynamometry style test and then getting whatever you need in terms of the readout to do, or in terms of the percentage to actually load the joint itself. So you've got the BFR going, and you've got, like I said, whatever you sort of want it to be. The concept is the same. There's actually other games. There's an isometric game where you're just trying to get into a little green screen or a little green envelope of, let's say 10 pounds plus or minus 1 pound, and you're sort of staying there for 10 seconds. Or you can do this slightly variable resistance isometric, and you can obviously do it at roughly 30 degrees, 45, 6, whatever, like as I said, whatever you feel like clinically is appropriate for that patient, but you're given at least the choice to do so. So, moving the latter phases 3 and 4, you start to do more of the external load, dynamic movements to assess and build tolerance to load and functionally progress our patients and clients. We start tying in performance coaches and trainers and coaching, skills coaches, teams coaches, and so on. I think it's important here, again, as we saw in the beginning, you may have a mild shift right to left unloaded in a squat, but how much of a shift do you potentially have when you are starting to load that squat? So when you're looking at later on, whether it's a loaded goblet squat, whether it's a front squat, whatever you're sort of doing, can you see that there may still be a shift or not? And do we want to reduce that load potentially as that patient's doing? Obviously, not everyone is going to do their entire workout or subsequent workouts on force plates, but the ability to bring these out of a bag, put them down, have somebody do a couple of reps, understand in front of a mirror, this is what you look like when you're 20% shifted or 10% shifted. This is what you look like when you're normal. Can you see the difference? Can you feel the difference? Does that hurt? And then let's try and do it without it. Can you reproduce that? I think that's very valuable, and to be able to whip that out is pretty good. And then you can use them like every other force plate, right? You can do a counter movement jump with it. You get on there, you can test them, certainly doing a kind of movement jump to assess all of the rate of force development, time in the air, all the other concentric, eccentric sort of stuff that we're looking at. And so what you're seeing here is some of that data. I don't think she was trying that hard, but there we go. So what you get from that is some of this data. So here is your squat. You're going to see every rep parsed out into concentric, eccentric load. You're going to see your weight shift, concentric versus eccentric. And I think that's really interesting to see of when you get all the way down to that eccentric load and it peaks, are you loading to one side and see she's still, I'm not going to call it fatigued at 5 reps, but potentially there's still a little bit more load, even though it's marginal, getting over to that right side. And then, so you get that breakdown. There's a little bit more data there. You get the very simple chart of 95% of your of the reps are seen in this dark green. The last 5% are seen outside. So very often she stayed relatively normal, but you'll see the light green bar actually be very wide because somebody might shift back and forth, but more or less their dark green bar sort of stays in one spot. It's tight, but it might be shifted one way or another. So in other words, what you're really seeing is you can concentrate, there isn't as much chatter. So if somebody, you're always worried about those, the outliers where if somebody shifts their weight one way or the other really hard, it might skew your results. Well, 95% of the time, you're going to stay within, 50% on the right, 49 on the left, or 45 on the right, I'm sorry, 55 on the right, 45 on the left, or whatever it is. So it breaks that out for you quickly. And then your kind of movement jump, right? You have your eccentric loading in the beginning. You can see the decrease. You can see the resultant force here. You can see the left and the right being fairly similar, but again, there's a little bit more load on that right side, and it gets down to the lowest part of her squat a little faster than the left. The left lags behind a bit. As she starts to produce force, what you're seeing is a production that probably could be a little bit steeper, but that's, probably maybe a training situation. But when you see the peak, the takeoff force, the right, again, a little bit, I'm sorry if it's tough to see, but the orange is the left. The right has a slightly higher peak than the left. And this is something to have a conversation about with your athlete, with your patient. In a hospitals-based setting, I think this is something we have a conversation about. In an out-of-network or out-of-pocket setting, I think this is something that really gets the point across that we're not trying to necessarily get more out of you in terms of visits. This is just the difference. If you're comfortable with it, it's okay. But this is what the numbers in a performance setting. I think these numbers are obviously critical. They're widely used. And then the landing, right? So here's your resultant factor. And again, the left takes a little bit less of the load, clearly landing a little bit more on the right side, favoring that side as you dissipate that load. And it's shown here in the strength development to the force plate, relatively much more on the right than the left side. So nice to get this kind of data, nice to talk about it, nice to be able to put it into your chart. And if you have something noted in your chart, you have that objective finding to right there, put it right behind it in your chart as well. So in conclusion, I didn't want to go too long. We have to save some time for questions, but patellofemoral pain is a complex diagnosis. We have to determine why the patient's having pain. There are multiple pain generators, and that is all, outside of really the use of objective measures in this setting. I think that's something as clinicians, you have to have a consistent way of testing that you can really objectify. What am I seeing? Why am I seeing it? How do I get this person better? And then you have to progress through your rehab, and these are empirical, but may not necessarily be linear. You may have to go back at some point. We do need to understand that it's a stepwise progression, it's a gradual progression, and there are aggravating factors along the way, but we as clinicians need to know, are we getting better? Are we not getting better? And to what degree are we not? So that we can make the appropriate conclusion of when do we back off or when do we push? And when do we say, look, I think there might be something else going on here. You got to go back to the doctor, or you have to go to the doctor or not, or you have to just stick with this a little longer. It just takes a long time. You've had knee pain for 10 years and you're perpetual subluxer. You're going to have some patellofemoral pain. You got to get stronger. So anyway, I hope this was informational. I'm glad to have done it. I think our profession, both in performance and in rehab, really needs a lot more objective measurement and a lot more empirical data that should be put into the notes, but should be really given back to the patients. And I'm open very much so for conversation. And then feel free to email me with any questions, any discussion on this stuff. I'm happy to field any question there. Just put like Kinvent webinar or something in the subject line, so I know it's not like a random email. So yeah, and so we'll open it up to any questions, anything like that. All right, so from yeah, so the insurance company doesn't. Thanks for the question, Kyle. So the insurance company couldn't care less that they're saving money. You're not going to convince them they're saving money. They save money when they don't give you visits. But The insurance company does have an algorithm that they utilize in order to either deny or allow for the person to have to utilize their benefits, and whether or not they've met their max therapeutic benefit. And so I think the thing to remember is that if you are showing a deficit in that patient, whether it's pain, whether it's strength, whether it's motion, whether it's a PROMS, patient reported outcome scores, I think those things are what matters to the insurance company. I've been a part of several companies that have tried to use various other metrics in order to show the insurance company that the way they treat cuts cost, or cuts the number of visits, so they should be reimbursed more per visit. I think the insurance company is fairly set in their ways, and I think for me, it's easier to fight them with the things they see as important, rather than trying to convince them that what I think is important is actually something they should really be looking at. I think if what I'm really seeing is that we're able to get more visits from the insurance, rather than have them somehow change the way they reimburse us per visit. So I hope that answers the question. So yeah, I'm happy for you guys to ask questions. Like I said, email me, but I hope this was helpful to those of you that are here. Yeah, so reach out.